Let's talk about special patient populations. First, we're going to start by talking about trauma patients and the neurocritical patient. So in this section, we'll cover trauma and neurocritical. In the next section, we'll talk about obesity, pregnancy, and some reactive airways. Let's start with a case on a trauma patient. So we have a 25-year-old male who was impaled when he was riding by a construction site and he crashed his bicycle. His airway's clear, but you notice there's some swelling and ecchymosis around his anterior neck and a large foreign body. You note worsening stridor when you arrive. Lung sounds are clear and equal, though. Skin's pink, warm, and dry. All things considered, he's looking pretty good at the GCS of 15. Vital signs are stable, maybe slightly elevated. SATs are in the 90s. So the rest of your exam is normal cephalic. He has decreased neck range of motion, of course, and some pain with palpation of the cervical spine. You note there's a clavicle deformity, but the remaining exam is atraumatic. So just thinking about patients like this who present some really special airway challenges. Obviously, we have to consider tracheal trauma in addition to trauma of the lungs or great vessels in this setting. But also, if we need to control the airway, how are we going to position this patient for optimal intubation, or is intubation the optimal procedure? So thinking about some of the clinical challenges. Additionally, we may have a patient with other types of shock. Hey, maybe neurogenic shock may develop or hemorrhagic shock. And then don't forget tension pneumo or hemopneumo could also be involved with this location. So we're thinking about the airway globally, right? Thinking about anatomic difficulties. Now for this patient, anatomically, before the rebar, he probably didn't have a lot of difficulties. But now we've added another variable. By all means, direct laryngoscopy will be very difficult due to our inability to position him properly. If we had to bag him, also difficult, especially as he's paralyzed. Extraglottic device might be a good alternative for this patient. And definitely we're going to need to consider a surgical airway. If we do decide that we have to control the airway, I would be doing a double setup, meaning one attempt from above and then going straight to a crike if I fail and I'm unable to oxygenate. So let's talk about airway injuries in general. So thinking about injuries, we want to think about maxillofacial trauma, anything to the anterior neck, smoke inhalations, and burns, to name a few. So I got to ask myself first and foremost, am I forced to act? Now, based on that one picture of that young man, it doesn't look like I am quite yet. He seems to be oxygenating, ventilating, and mentating just fine. But I need to be worried about the clinical course here. And do I have a hematoma of the neck? Is it rapidly expanding? The stridor is the big clue on this patient that I may need to act quickly, and I may rapidly end up in a forced to act situation. So avoid delay if we think that this is rapidly expanding hematoma, and the stridor in this airway is what has me the most concerned. When we're talking about burns, right, these are ones we want to think cautiously about. If we think there's burns to the airway structures, stridor is a good hint. You can have some facial burns and singeing of the facial hair and nasal hair without actual airway burns, so don't jump the gun too soon. But if the patient's showing any signs of respiratory compromise, getting them intubated sooner than later may be really beneficial. And then ask yourself, are these candidates for awake intubation? The patient with the rebar, for instance, this is not someone I want to lay down. I want to paralyze. I want to reposition his airway if I don't have to. So maybe I'm going to pre-oxygenate this patient really well, get them to the hospital where I can optimize their hemodynamics and their oxygenation and have a more sort of controlled awake intubation as an option, assuming you're not forced to act. So let's move down sort of the body, if you will, when we're thinking about traumatic injuries. So let's start by talking about TBI. TBIs are the most common intubation or indication for traumatic intubations. This was seen as 12% in an ER registry study. So the big goal when I'm managing a patient with TBI is to reduce the risk of the secondary injury. So the brain injury that has happened, I can't help that. That's what's done is done. But the big things that will kill these people and make these injuries much worse from a secondary standpoint are patients that we allow to get hypoxic or hypotensive. So we want to keep that systolic blood pressure with a bit of a cushion if possible. keeping the systolic over 100 or 110 can be helpful. So we don't want to profoundly drop their blood pressure, as this may cause significant worsening of the already traumatized brain. Ensure that we have optimal saturations, and remember, use your cardiostable medications. Both etomidate or ketamine are safe in patients with traumatic brain injury. There's no evidence that either of those specifically causes harm. And then something we'll talk about a little bit today is the use of fentanyl or other medications for pre-treatment if I have a hypertensive crisis in addition to my traumatic brain injury. So hypertension with suspected ICP, we'll talk about some of the harms we can do with laryngoscopy. And above all, we want to make sure that we are avoiding adding harm. So hyperventilation specifically is out. Do not hyperventilate your patients with traumatic brain injuries, as you can cause significant worsening. More on that in a minute. Working our way down, thinking about head injuries, often they have accompanying cervical spine injuries. So patients who need some spinal immobilization, who also may be at risk for aspiration, as often head injuries may be accompanied with intoxication in addition to the trauma that they've experienced. So if we're intubating patients with cervical spine immobilization, make sure you take off the C-collar, because yes, we don't want to move the spine. We don't want to put them in a sniffing position, but I do want to be able to open the mouth wide and manipulate the jaw. So having a partner holding C-spine and even giving you a jaw thrust while you're intubating a patient with spinal immobilization can be really helpful. Make sure we're doing pre-intubation neurochecks. Now, I don't belabor the point of sucks versus rock on these patients to a great deal. I think either one is fine. But if you're using rocuronium, make sure you do a neuro exam as best you can to get an idea of what the pre-intubation neurologic status was. External laryngeal manipulation, video laryngoscopy, and the use of a bougie can all help with first pass success in patients with reduced spinal immobility. So this goes for our trauma patients who we want to avoid moving, but it also goes for patients with spinal fusions and other anatomic features that don't allow us to move the head. A lot of times these patients will be multi-system trauma, which complicates the vignette significantly, to say the least. So thinking about chest trauma, we need to think about things like pneumothorax, hemoneumothorax. So in addition to obstructive shock and hypoxia, these patients can also have hemorrhagic shock. Flail chest segments cause a great deal of pain. This makes it harder to pre-oxygenate these people, as they can't take big breaths in. So we're not wrapping these flail chest segments like maybe we did years ago, but definitely treating the pain for these patients is really important. And then knowing any kind of chest trauma is actually an independent predictor for peri-intubation cardiac arrest. This is twofold. One, because it's harder to pre-oxygenate them, as they have more atelectasis from not taking deep breaths. But additionally, there may be a multi-system trauma and multivariable shock situations that are making this more dangerous. So impaired gas exchange and ventilation can make it really hard. Make sure if you're concerned for simple pneumo and you have to intubate someone, you keep an eye, because that may quickly go into a tension pneumo. Look for open chest wounds. Make sure we stabilize the ABCs before we move to intubation, especially if we're not forced to act. Consider needle decompression. So definitely if you have unilateral lung sounds and JVD in the setting of shock, needle decompress that patient. If you have point of care ultrasound, this is actually a great place to use it, because you can check for lung sliding and rule in or rule out pneumothorax a lot more accurately than just lung sounds alone. But no, if you are suspecting a simple pneumo, putting them on positive pressure ventilation may quickly convert them to a tension pneumo. And additionally, think of the other things within the box. If I have chest trauma, I also could have cardiac trauma. So patients can have tamponade or even just pulmonary contusions or injuries to the great vessels. Patients who have tamponade, remember Beck's triad, right? So if I have normal lung sounds, hypotension, and I see JVD, I should be concerned about tamponade. Listen to the heart tones. Do they sound muffled or distant? It's worthwhile to check. Now, these patients are really preload dependent. So tamponade in and of itself, giving IV fluids can really help. But we're going to need to be cautious in our multi-system trauma patients because giving too much fluid could hurt a patient who has hemorrhagic shock. Likely, your cardiac tamponade patients will decompensate quickly after you give induction agents and put them on positive pressure ventilation. So be very cautious about intubating these patients with chest trauma. Not only do we need to worry about the lungs, but we need to worry about the heart and potentially obstructive shock from either. Last note on tamponade, most EMS systems don't have pericardial centesis in their protocol, but if you do, it's in the setting of a traumatic cardiac arrest. This is the patient who it's worthwhile to do pericardial centesis. And then medications, full doses of paralytics for sure, or even double dosing them is fine. And then the same rules for medication apply here. If I have a patient who's obtunded in refractory shock, I'm probably going to go low on my sedative agents because they probably don't need that much sedation. But if they're wide awake and I have been able to resuscitate them, then I can probably give full doses. But definitely don't skimp on the paralytics. Let's talk about a little recent evidence that came out. So this study was a 2023 study, and it was looking at optimal crystalloid resuscitation in the pre-hospital setting in patients that were at risk for hemorrhagic shock. So spoiler alert, what they found overall was there was an association with higher mortality and a patient getting more than 1,200 cc's of crystalloid. Now, if you have a blood program, then you don't have to worry about this quite as much. But if you don't have blood, we need to be cautious about how much crystalloid resuscitation we're giving to patients who have risk for hemorrhagic shock. When we're thinking about hemorrhagic shock, if it's something external, then I may be able to stop the shock and resuscitate them fully, right? If I can stop the bleeding. If it's internal, though, it's a lot more complicated. So our resuscitation goals should be a systolic about 80 or 90, not the MAP. Remember, resuscitating to a MAP of 65 can actually lead to really high systolic pressures, which we don't want in someone with hemorrhagic shock. Now, give them up to a liter of fluid to get to this goal. But the evidence is really saying that, hey, after a liter, the chances of harm are just too high. So stop at a liter. Hang a liter bag and don't hang another. If you have blood, give blood. That's the short of it. If you don't, then work with what you got. Now, a point of contention or something that we've taught classically is, hey, if someone's in hemorrhagic shock, under no condition should you ever give them any vasopressors. Well, there's some challenges to that, as not all EMS agencies have blood. Now think about this. You have a patient in hemorrhagic shock. You've given them a liter of blood. Their blood pressure is now, you've given them a liter of IV fluids. Their blood pressure is now 60. They're pale. They're cool. They're diaphoretic. They're obtunded. They are peri-arrest. What are you going to do as soon as their heart stops? You start CPR and they go into PEA. You give them a milligram of epinephrine per ACLS. Now, this is a whole nother debate, right? ACLS isn't really made for traumatic arrest, but we have a bit of a logical fallacy here to say never ever give any vasoactive agents, but as soon as they lose their pulse, we're going to give them a huge slug of epi. So I really think it's reasonable if you have this patient who's peri-arrest, who's already gotten a liter of fluid, to start low and go very slow with an agent like norepinephrine. Start at 1 or 2 mics and gradually titrate up, not even to try to get the pressure of 90, but just get to a perfusion where the patient's brain is perfusing, where you see some improvement in their skin signs. This is just to keep them from arresting so you can get to the hospital and get blood for them. So I would stay away from push dose epi in these patients, as you may have these big swings in blood pressure. So yes, generally speaking, if the patient needs blood, give blood. If you don't have blood, give a liter of crystalloid. If you've done that and they are about to arrest on you, I think it's reasonable to start low and slow with a vasopressor just to get them to the hospital. And then don't forget, shock comes in many different flavors. the non-hemorrhagic causes such as tension pneumo, tamponade we've talked about. But also patients can be in shock from myocardial contusions. They can even have neurogenic shock. So keep your eyes out because each of these types of shock have a little bit different treatment. So when we're thinking about our resuscitation in these patients, if I can't resuscitate you enough to intubate you safely, and I'm not forced to act from an airway standpoint, I'm probably going to use BLS maneuvers to keep you oxygenated and work on keeping you from becoming hypotensive before we get to the hospital. Next, let's talk about a little bit more about elevated ICP and hypertensive emergencies. So sometimes these go hand in hand, but not always. Let's start with a case. So don't drink and drive. This is a 28-year-old male who had injuries from a fall. He was about 9 feet up and he fell onto the concrete because he was on his also intoxicated friend's shoulders. When you show up, there's no eye opening, there's no verbal response, but there's some like withdrawal from pain. His airway is clear, there's no snoring, lung sounds are equal, and he actually has a good tidal volume. Skin is pink, warm, and dry. He's hypertensive, bradycardic, and has irregular respiration. Remember that triad? Cushing's. So Cushing's is an indication that the patient may be suffering from some increased intracranial pressure. But this patient in this case has good SATs and he seems to be perfusing well. On your exam, you see a large hematoma on his occiput. His pupils are sluggish, but they're equal. And the rest of his exam is actually pretty benign. So what are the risks here? So from an anatomic standpoint, just at a glance, this is a young man, no obesity, no beard. I should be able to intubate him. I should be able to bag him. If I need to use a supraglottic, should work. And worst push comes to shove, if he needs a crike, I can accomplish that. So anatomically, not a lot of difficulties aside from, remember, the C-spine immobilization, but we have some ways to overcome that. This is really an issue of physiology in this patient. So clinical challenge with increased ICP. So this occurs when the body's lost its ability to auto-regulate appropriately. So it can be due to trauma, or don't forget, it can be from a catastrophic bleed. So a patient who's even young, who has a subarachnoid hemorrhage from a spontaneous aneurysm, these patients can present this way as well. So when we think about cerebral perfusion pressure, or CPP, this is actually a product of MAP minus the intracranial pressure. So the MAP, take away the pressure, is the perfusion that the brain is getting. So if the intracranial pressure is rising, the patient's MAP will rise to overcome it. And the body is trying to basically regulate to keep a cerebral perfusion pressure. Excessive BP elevation or depression can actually cause ischemia or edema to the brain. So we don't want to cause a lot of big shifts in the patient's blood pressure. Even short periods of hypotension, so dropping of blood pressure from 180 systolic to 100 systolic, and even a slight amount of hypoxia are linked to increased mortality for patients with increased ICP. So although this high blood pressure is disturbing, we don't want to intentionally drop it too quickly, especially when we're not exactly sure what the insult is. So there's some reflexes that respond to laryngoscopy that can actually make intubation, just the skill in and of itself, dangerous for these patients. So from a sympathetic nervous system standpoint, these patients have a big catecholamine surge, and we can actually cause increased catecholamine release. This worsens with multiple attempts, especially if our sedatives are wearing off and we have patients that are awake under a paralytic. Now, just stimulating the oral pharynx can cause an increase in ICP, and definitely cough reflex can increase the ICP. So paralytics are really important for these patients. We want to make sure they're fully paralyzed before we try to intubate them. And then remember your neurovascular blocking agents. Either one is actually okay. Succinylcholine, in the past, we saw some slight increase in ICP, I think due to the fasciculations, but in reality, it's not contraindicated because this wasn't clinically significant. So you can use succinylcholine or rocuronium in a patient with suspected ICP or head injury. They're both fine. So hyperventilation. This question has been sort of volleyed back and forth over the years. The big take home is don't do it. It hurts people. It increases mortality. There's a study done last year that said, hey, patients who have an end tidal CO2 less than 35 in the field actually had higher mortality. So here's the thought process behind this. We used to say, hey, if a patient has increased pressure in their brain and we think there's signs of herniation, then we should hyperventilate them. This will vasoconstrict the blood vessels to the brain, decrease the swelling, and hopefully decrease the herniation. The reality is here, we were just robbing Peter to pay Paul, because causing all of this vasoconstriction to the brain means we don't have oxygen delivered to the brain, we don't have blood delivered to the brain. So we're causing worsening ischemia with hyperventilation. So don't hyperventilate these patients. Keep their end tidal on the low end of normal. I think that's reasonable, but we don't want to let it drop below 35 because that seems to be the number that showed the most harm. So you don't have to worry about if it's Cushing triad with or without herniation. Those sort of signs and symptoms shouldn't dictate how fast you bag the patient. The take home is keep it above 35. Now, there's been some talk about medications to blunt this huge sympathetic surge. Lidocaine was recommended in the past. It's been out of most algorithms for about a decade now. There was some mixed evidence, but mostly it was never proven to cause, any benefit. So it's really just increasing cognitive load, and potentially there can be some bad side effects with giving lidocaine. So not recommended to pre-medicate with lidocaine for increased ICP. Now, short-acting beta blockers are another one we want to stay away from because we don't want to precipitously drop the blood pressure. We want to reduce anything that increases ICP, but we also want to reduce anything that decreases perfusion, as this makes the brain ischemic and potentially can cause more harm. So very problematic, as there's a lot of hypotension. So stay away from the beta blockers, even when you see really high blood pressures. Fentanyl is something that's been discussed over the last few years. It doesn't have really high evidence, but it's thought to be something reasonable in your patient with a huge sympathetic surge, like giant blood pressures. Giving a dose of this 60 seconds before you give your other induction agents, over 60 seconds, so push it very slowly, and you give it 3 minutes prior to your actual intubation, maybe that's protective. Jury's still out on this. So sum this up, lidocaine's a no, beta blockers are a no, and you know what, maybe fentanyl, but I need a little bit more evidence on this before I'm going to routinely use these for my patients with ICP. Induction agents. The big take home here is they're both great. Again, there's arguments and studies that are pro and con for each of these medications, but these are both great. Historically, and in the last version of the Walls manual, they were really super etomidate heavy. So historically, etomidate was thought to be the preferred agent for head trauma because it has some favorable effects on metabolic oxygen demand. Specifically, it may reduce the hypertension without reducing the cerebral perfusion pressure. So it maintains the cerebral perfusion pressure, even though you see a little decrease in the blood pressure. Now, ketamine is definitely not contraindicated, and there's some studies that show, hey, maybe ketamine's the way to go. Ketamine does increase ICP because it increases blood pressure, but it turns out it's also it maintains cerebral perfusion pressure as well. So I would still use caution if someone is severely hypertensive, just because I don't want to give them more sympathetic surge, which they may see with ketamine. But remember, both of these medications can drop blood pressure in these patients. So we want to be cautious and we want to be thoughtful. If your patient is already obtunded and their GCS is very low, like the case we just covered, they probably don't need much of either of these medication to induce them adequately to intubate them. So these are patients I might consider going a little low on these agents. Which agent you give is probably not as important. So here's a study in 2024. It was looking at etomidate versus ketamine for pre-hospital induction agents, specifically with patients with severe traumatic brain injuries. So it's a big pre-hospital data set. Okay, so this is retrospective. It's observational trial. So keep that in mind. They're looking back at data. A lot of patients, though, 1,450. And it was an etomidate heavy group. Remember, it's not randomized, it's not controlled. So almost 1,000 of them had etomidate and almost 500 had ketamine. 70% were male, which is not a surprise because these are trauma patients, and the median age was about 45. So generally young people, keep that in mind, okay? We're not talking about little old people with heart conditions here. 30-day mortality is what they wanted to look at, and really there's no difference. So my big take home here, both good medications, head injury, dealer's choice. Now, because this is observational data and not randomized, you have to take some of these secondary outcomes sort of with a little skepticism because they saw a good neurologic outcome was a lot higher in etomidate than it was in ketamine. I wouldn't take this to the bank because, again, this study was etomidate heavy, which tells you that a lot of the people were picking etomidate more often than ketamine. And also the people who picked ketamine may have picked it because they thought it had some benefit because they thought there was a benefit to not dropping blood pressure. And maybe they were picking ketamine in sicker patients. Regardless, this may be an outlier as this is observational data because in the randomized control trials, we're not seeing big differences between these medications. So the big take home, etomidate or ketamine, they're both probably good agents for both traumatic brain injury patients and trauma patients in general. Now, we did look at some peri-intubation hypoxia after delayed sequence intubation. This is a 2023 study specifically on trauma triage patients. This is an in-hospital study, but it's in the ER trauma base. So these are the same patients you're seeing in the pre-hospital setting. So they wanted to know which was better for these patients, delayed versus RSI. So it's a randomized control trial, which is great, but it's only 200 patients. I mean, the reason for that is they excluded a lot of patients because they wanted to answer a specific question. If I have a trauma patient who is agitated, and really the take home is they're difficult to pre-oxygenate because they're agitated, which one of these methods would work best? So half of them went to rapid sequence intubation and half did delayed sequence. And so for rapid sequence, they pre-oxygenated them the best they could for 3 minutes without sedation. And then they gave ketamine and a paralytic right after and intubated them. For the delayed sequence intubation, the ketamine came first. So sedation with ketamine, and then they spent 3 minutes pre-oxygenating a patient who's no longer agitated. Then they still used the paralytic after they were done pre-oxygenating, and they intubated the patient. So let's see what they found. RSI, again, 3 minutes of pre-ox as best as the patient will let you. Then they gave both medications back to back. Delayed sequence intubation, ketamine first, 3 minutes of pre-oxygenation, then paralytic before intubation. In the RSI group, they had really high rates of hypoxia, 35%, and a low first pass success rate at 68%. Now, this could be a couple things, right? But if my hypoxia is a really high rates of hypoxia, I'm not going to have as much time to intubate. And these might be technically a little difficult intubations due to cervical spine or even airway contaminations or all the other trouble that comes with traumatic patients. But these rates of hypoxia are a lot higher than rates of hypoxia that we're seeing in other studies. So this is a sick cohort. The patients who got delayed sequence intubation did a lot better. First pass success was 83%, and the hypoxia was very low, 8%. This is actually lower than hypoxic rates in general RSI patients in other pre-hospital studies. We're usually seeing rates around 20%. So bringing that hypoxia all the way down to 8%, that's pretty profound. That's pretty impressive. They didn't see any higher rates of aspiration or other complications in the delayed sequence intubation group. I think the evidence for delayed sequence intubation is growing. Now, I can't say definitively that doing DSI on every patient is the right way to go because we may have more instances of complications if we open it up to everyone. But it may be, when we have more evidence to show that, then I think that's a promising technique. But for now, if you have a patient who's difficult to pre-oxygenate because of agitation, try DSI. This is quite reasonable, especially in these traumatic injury patients. So paralytic of choice with trauma. Long story short, it doesn't matter. Both sucks and rock are reasonable. Just remember, sucks when I'm thinking trauma, think of crush injuries as a contraindication. If they have increased ICP, that's okay. Succinylcholine doesn't show necessarily worse outcomes. And it may have some benefit in those repeat neuro checks. But in my book, do a neuro check before you intubate them, and you don't need to worry about this as much. Rocuronium, it lasts longer, right? So a little bit more time before they can get their neuro checks, but there's no real contraindications or cautions when it comes to trauma. 2024, let's see what we talked about for evidence. So we looked at in-hospital mortality after pre-hospital intubation. So this is specifically looking at pre-hospital patients who are either intubated or had other methods used, such as supraglottic. This is a cohort study. So they wanted to know, is it better to just put a supraglottic in these trauma patients and roll with it? Are we wasting time with intubation? Are we causing more hypoxia? Are we causing hypotension for patients we can't resuscitate? So let's see what they found. It was a big study. All trauma airways specifically, 10,000 patients. Now, this study was a physician-run EMS agency in Germany. So maybe not generalizable to where you work, as these are physicians that are doing the intubations, but they're the same patients you're seeing pre-hospital. And what they wanted to know was in-hospital mortality. So the patient was intubated out of the field, and what was their mortality overall? So first, let's talk about the intubated patients. Most of this group was intubated. So this is an observational trial. It's not a randomized control trial. So 92% of them were intubated, which leads me to believe this cohort thought that was the better thing to do. The mortality overall for these patients was 33%. So again, a really sick cohort of people on this. They looked at on-scene time. It was about 35 minutes. And then the time to get to the hospital was 73 minutes. So definitely outside of our golden hour. Generally, when they compared this group to the ones who got supraglottics, these were sicker patients, which makes sense. If we're not randomizing and controlling, it's the sicker patients who probably need airway protection. And in this setting, they were going for intubation. So interestingly, about 7.5% of them got supraglottics. So for these patients, it was 30% mortality. This wasn't statistically significant between the two, but their on-scene time was quite a bit faster at 27 minutes, and they got to the hospital about 10 minutes faster on average. Really, the problem with this trial is it's a small sample, right? It's a very small number that got supraglottics, but it does raise the question, are we harming patients with intubation? Could those long on-scene times potentially lead to more harm overall, especially if you have a system where you can't give blood or do other interventions like that? Getting to the hospital quick may make a big difference for some patients. So I think the take home here is supraglottics are reasonable. If you have a patient with a complicated extrication who you can't position well to control their airway, supraglottic's a great way to go. Confined spaces or a helicopter ride, supraglottic may give you an airway that and get you to the hospital. So keep this in mind. If you have a good reason not to intubate, but you need a little bit better airway protection, consider a supraglottic. Jury's still out now to prove that supraglottics are just as good as intubation or maybe better. So be looking out for new data hopefully coming. So let's sum it up. Overall, our approach is really to optimize oxygenation. If I can keep a patient oxygenating and ventilating adequately, I should really ask myself, do they need an intubation? Is this forced to act? Do they need plastic through the vocal cords? Or do they just need BLS airway protection? My goal is normal capnia, so don't hyperventilate them. Keep that end tidal above 35. And then one last note, if we have patients with chest injuries or head injuries and hypotension, just remember that be careful with your PEEP. Avoid really high PEEP or inspiratory pressures if you're using a ventilator. If you don't need those high pressures to adequately oxygenate the patient, avoid them because we might have bigger problems with hemodynamics and the different shock states. So that is all for the traumatic patient. Let's quickly take a moment and talk about some other neurocritical patients that we might see. So patients with prolonged seizure activity provide some clinical challenges. We'll start this one with another case, this time a 6-year-old. History of seizures, but the parents called 911 because they'd already given some diazepam pararectally without the seizure stopping. So you get there, her gaze is fixed, she's non-verbal, she's posturing. When you look in the airway, it looks clear, but there are secretions and she has a clenched jaw. Her breathing is shallow and erratic, and although she's tachypnic, you can hear lung sounds bilaterally. Skin is pink and hot, she's sweaty, but she has perioral cyanosis. When you look at the vitals, actually for a 6-year-old, not too bad, except for that saturation, 89% on room air, and she's afebrile. Overall, the exam is atraumatic. You see this tonic-colonic activity. You look at the pupils, they're pearl. You're not suspecting some sort of trauma or febrile seizure. And this is a 6-year-old who is in status. So by definition, this patient is in status when you arrive because she's still seizing. So let's talk about our clinical approach. So if you come across a patient who's still seizing when you get there, this is a status seizure. Most seizures will terminate and are self-limiting in about 2 to 3 minutes. So often you'll show up and the patient will be postictal. A status seizure is, remember, we define it as greater than 5 minutes or more than one seizure without waking up in between. Those are both defining of status. Now, true status has a high mortality rate, like 20%. So these patients are very sick. They have a very high metabolic demand. These patients can have really bad consequences if we allow them to continue to seize. So advanced airway protection is actually rarely needed most of the time in seizures. Even in patients with status, with clenched jaws, often we can put a nasal trumpet in, we can suction with suction, we can provide flush rate oxygen or gentle ventilation if need be. But the really challenge comes when they are seizing so much that we can't oxygenate them and ventilate them. So prolonged seizures actually bring a lot of physiologic difficulty because they raise the metabolic debt and they cause acidosis from a lactic acidosis. In addition, they can become hypoxic and even develop rhabdomyolysis, which can lead to acute kidney injuries and further exacerbate the acidosis. So make sure that we're looking for other causes of the seizure, thinking about temperature, but typically febrile seizures are not status seizures. Always check a glucose and make sure you rule out the hypoglycemia. So when we're thinking about some of these difficulties, they can be really difficult to pre-oxygenate due to the dyssynchrony. So likely, if we're not able to oxygenate them, we may have to paralyze them specifically to stop the dyssynchrony so that we can oxygenate and ventilate them. So if you have to paralyze a patient who's in status seizure, who's hypoxic, don't jump right to the intubation. Bag them back up, get those SATs up, maybe put in a supraglottic. However you oxygenate the patient, don't delay oxygenation because you're rushing to intubate. RSI, etomidate, or ketamine are reasonable. Now, there's some discussion out there about ketamine maybe having some anti-seizure qualities. So far, the evidence isn't high, but I think it's reasonable enough to say I would pick ketamine over etomidate if I was going to RSI a patient who is in status seizure, because there may be some benefit. We'll see if some more evidence comes out on this. But just like last month, 2025, December, a study came out that's a pre-hospital observational trial. It's kind of interesting on this. They showed patients who had 2 doses of benzos and were still seizing. A lot of them, their seizures stopped after giving ketamine. So is that correlation or causation? Hard to say, but I think the evidence is pointing that ketamine might be the the medication of choice for these patients. Acetylcholine is reasonable for reassessment, but think twice before you give it, because remember, these patients can have a metabolic acidosis, which can lead to hyperkalemia. So be careful when you're considering acetylcholine. I personally would pick rocuronium. Now, the problem with rocuronium is once I give rock, I don't know they're seizing, but they're still seizing. I just can't see it. So if I've given rocuronium, it's really important that when you get to the hospital, you let them know this patient is still seizing. They're just paralyzed. So I may schedule my benzos on the way to the hospital and keep redosing the ketamine. It's sort of the best we can do pre-hospital at this point. Now, there are some EMS systems that have Keppra, and by all means, that would be great to give in this situation. But when they get to the hospital, we're probably going to put them on a propofol infusion and give them some other anti-seizure medications. But what we want to avoid is continuing to paralyze them if not needed, because we'd like to see those seizures if possible. So that's sort of the general clinical approach for status seizures.